All right, so I'm Drew, one of our two urology residents here at UBC. I'm going to be talking today about Peyronie's disease and an update on some of the management options for this disease and what's kind of new and upcoming in the world of Peyronie's disease. So these are the objectives. We're going to talk about Peyronie's disease, what it is, how it works, and what you should know when you're working up a patient. Talk about the non-surgical options, and then review development pathway of the Xiaflex compound, how it came from an idea to a treatment, and then to talk about new options that are being investigated that are still kind of in the pipeline. So Peyronie's disease, first described in 1743 by Francois Guigot de la Peyronie as induratio penis plastica, where he noticed curvature of men's penises. And he trained initially as a barber surgeon, so he's cutting hair and cutting people. Barber surgeons at the time were mainly used for bloodletting, and he eventually became the first surgeon of King Louis after more formal training, and later passed a law prohibiting the ability of barbers to perform actual surgeries. Thank goodness. So Peyronie's disease, it's an acquired disease of the tunica albuginea. The albuginea develops fibrosis and causes eventual curvature of the penis over time. Patients will come to the office complaining of most notably a visible deformity, but can also have pain with erections, notice a palpable plaque within the penis, or have penile narrowing or shortening, and this can be associated with erectile dysfunction as well. It is quite common in up to 9% of the population. It's kind of variable depending on the case series that you look at, but the most consistent number is around 9%, and has a very high impact on the quality of life on these men, but not only them, their partners as well. The pathophysiology of Peyronie's disease isn't really well understood. However, it's thought to be kind of a disorganized healing process after trauma or microtrauma. Collagen is laid down in a haphazard orientation, and there's decreased elastin filaments in the plaques themselves. And TGF-beta, reactive oxygen species, and nitrous oxide are thought to be key inflammatory mediators that will proliferate this plaque and cause progressive damage. Here's sort of a schematic in Campbell's. I talk about a penile trauma being the inciting event, deposition of fibrin, recruitment of inflammatory cells and platelets, which then gives off inflammatory mediators, reactive oxygen species, and that attracts fibroblasts, myofibroblasts, which are responsible for scarring, tissue healing. They produce excessive collagen. You develop a penile plaque, coupled with increased nitric oxide and sort of a feedback loop of all these inflammatory mediators feeding the fibroblasts to create more collagen. Will lead to further plaque development and eventually plaque calcification. So this is just an outline of some of the variable nature of the disease. When a patient comes into the office, it's important to take a thorough history and do a physical examination. Peyronie's disease has two sort of known states, stable versus active disease. Stable disease is when patients have a plaque that's no longer changing in size or the amount of curvature of the penis, thought kind of over 1 year's time. And then the active phase is anything less than that, where they are having progressive curvature of the penis. Comorbidities associated with Peyronie's disease include diabetes, erectile dysfunction, Dupuytren's contractures, Lederhose's disease, and hypogonadism has been discussed as well. Dupuytren's contracture is the tightening of the tendons in the hand, and Lederhose's disease is similar but in the foot. These are heritable diseases. Thought to be about 30% crossover between the two, Dupuytren's and Lederhose's and Peyronie's disease. There's a questionnaire, the IIEF for erectile function and the PDQ for Peyronie's disease. Specific questionnaires will give you an idea as to how your treatments are going and just exactly how symptomatic patients are. Patients will often come with images to the office, and these can be useful in determining what exactly their amount of curvature is. Stretch penile length is another marker for how treatment can be going. And then artificially induced erections are kind of the key to perform in the office to really get a sense, an objective sense of the degree of curvature and allow you to plan your management strategy moving forward. For investigations, the main thing that's required is a penile ultrasound just to characterize the penile plaque. This will tell you if there's any calcifications, which we'll discuss a little bit later. Determine if injection therapy or any other therapy is worthwhile or having to go straight to surgery if it's too extensive. Blood work may be indicated if you think there's another cause for erectile dysfunction. Duplex ultrasound can give you an idea as to the vascular supply of the penis and whether or not there's going to be any need for other interventions. MRI has been discussed in mainly the US studies, but hasn't really taken hold here, and its use in Peyronie's disease management is still up in the air. So here's just a slide on the ultrasound, what it kind of looks like. It'll tell you the extent of calcifications within a Peyronie's plaque. Seen here, this is a longitudinal section of the penis. Oh goodness. Here is the plaque here and shadowing beneath it. So there's different gradings based on ultrasound, sorry. Grade 1 is a plaque less than 0.3 centimeters, grade 2, 0.3 to 1.5, and grade 3, greater than 1.5, or multiple plaques greater than 1 centimeter. As mentioned, the plaques with this rim of calcium have a shadowing artifact deep to them, and it's good for assessing vascular anatomy, as mentioned. So the Peyronie's disease questionnaire, what is it? It's a questionnaire that gives you objective data on patients' subjective symptoms. It was developed over about 8 years and really was necessary moving forward to FDA approval for a lot of injection therapies. It has 3 domains: psychological and physical symptoms, penile pain domains, and overall symptom bother and how big an impact this has on patients' quality of life. So that was kind of the workup. Now I'll talk about some of the non-surgical options for managing Peyronie's disease. There's been a ton of work in trying to treat this disease non-surgically. The aim is, of course, to fix the curvature with the easiest treatment possible. Easiest treatment is to do nothing, and we'll see self-resolution in Peyronie's disease in about 12% of patients. Traction devices have been used and actually do offer patients benefit. We'll talk about that in a second. Medical therapies have been tried, including oral, topical, and intralesional injections, which we'll spend the majority of our time today. Extracorporeal shockwave therapy has been tried as well with not so great results. Radiation as well. And then surgical is the ultimate treatment at the end of the line for patients who don't tolerate any medical or are unwilling to go through medical treatment. Here's just an example of some traction devices, or torture devices, if you will. The one on the left is kind of the initial model that was brought out, and it just pinches the glands, and you use these rods here to gently increase the traction on the penis over the course of your therapy. This is the model that we use here at VGH. This little egg-looking thing here is a suction cup that goes over the glands. This is where a little suction device fits on, and you kind of pump it up. Then you secure that into this plate here, and then you have the same extendable rods to put the penis on traction. As you can see here, there's a variety of fashionable ways to wear your Pennymaster Pro to keep it discreet. I prefer this lumberjack model here. So what's the evidence for traction? I mean, it's a pretty crazy looking device. There's been multiple studies looking at this, mainly small cohort or case series. Scropo et al. In 2001 showed 8 men with Peyronie's disease in the more stable phase, greater than 3 months, with no erectile dysfunction, using the device for 4 hours a day for 3 to 6 months, had an increased penile length of 4 millimeters, and reduced curvature by 14 degrees. There was no controls in this study. Gontero and his colleagues studied 19 men, and they had over a year of stable Peyronie's disease with curvature less than 50 degrees. They studied traction therapy for 5 hours a day minimum, up to a maximum of 9 hours. 15 men completed the study, and they had a mean overall change of 31 to 27 degrees, only 13%, so not as significant there. And the best study I could find for just traction alone was the Levine et al. In 2008. They wore the device for 10 to 8 hours a day in 10 men for 6 months and extended the stretch rods in 0.5 centimeter increments every 2 weeks, which is quite aggressive, I think. At 6-month follow-up, they showed improvement of 22 degrees or 33%, and the stretch penile length increased between 0.5 and 2 centimeters, so patients were overall quite happy with that treatment. Most recently, Moncada and his colleagues in 2018 published a paper on over almost 100 patients with Peyronie's disease for greater than a year, greater than 45% curvature, 45 degree curvature, and that had been stable for over 3 months. They used the Pennymaster Pro, which we use here, and controlled for not using the device. Recommended 3 to 8 hours per day for 6 weeks, and their primary outcome was improvement in curvature and improvement of the PDQ score. They found there was a dose response to the amount of time that you placed your penis on traction. Using the device for less than 4 hours per day, patients had a 28.8% improvement overall at the end of the study. And if you used it for over 6 hours per day, you had a 51.4% improvement in the overall curvature of your penis. The observation alone cohort had no significant difference between baseline and the end of the study. The PDQ questionnaire showed significant improvement in the domains of physical symptoms here on the left and on overall bother or distress that the Peyronie's disease gave to the patient. So pretty significant and a minimally invasive way to treat Peyronie's disease. Some of the most effective treatments that we have non-surgically are these intralesional injections. And the first player that kind of came on the block was Verapamil. It was first started in patients in the 1990s. And Verapamil inhibits calcium-dependent extracellular collagen transport and upregulates collagenase activities within Peyronie's disease plaques. There was multiple studies with benefit, but it was very variable in terms of the treatment and the response of patients given the heterogeneity of the disease, different design studies, protocols, very difficult to control, but did show overall improvement in patients' curvature and quality of life. Predictors that were identified by a couple of investigators showed that higher dilutions and greater baseline curvature, as well as having a younger patient at baseline, were indicators of good response. Arena and his colleagues in the early days of Verapamil had a study of 40 patients, those with active or stable disease. The patients with active disease overall showed a 50% improvement in the curvature of their penis, while those with stable, more calcified disease had only a 10% reduction in their curvature. So this gave us our first indication that Verapamil may not be effective for calcified plaques, but did show benefit for the active phase where that collagen is being actively deposited in the plaque. And this kind of makes sense with the way Verapamil works, inhibiting the calcium-dependent collagen deposition. The second intralesional injection that was tried was Interferon alpha 2B. It's a compound that adjusts the inflammatory process, decreases fibroblast proliferation, and overall decreases the amount of collagen that's produced in the plaques. A single-blinded multi-center control trial by Hellstrom of almost 120 patients with a mean history of disease of almost 2 years, injected interferon alpha, 500,000 units, each week for 6 weeks into the lesion. They re-examined and questioned the patients with IIEF at least 4 weeks post-treatment to determine the response. They also measured the penile curvature and overall showed an improvement of 27% versus 9% in the control arm. They had great benefit with the painful erections. Patients generally said that their erections were less painful, about 70% versus 30% with the control arm. and the plaque size was seen to reduce as well. Side effects of this treatment are flu-like symptoms, sinusitis, swelling, and bruising, kind of from this systemic inflammatory response. There's been other retrospective studies which have shown benefit, but yeah. The biggest kind of advance in Peyronie's disease treatment in the last few years has been Xiaflex, or collagenase Clostridium histolyticum. It is a mixture that contains two different collagenases, both from the Clostridial species, AUX1 and AUX2. Here's an idea of what the collagenase looks like. It's this kind of C-shaped vice grip that will slice up collagen here, and you can see the triple helix, and so it kind of moves down the collagen fiber and degrades that in a stepwise fashion. The early studies showed that elastin, vascular smooth muscle, and axonal sheaths appeared to be unaffected, and the collagen in these samples were not degraded by the collagenase. And it was rapidly inactivated systemically in the plasma, so we weren't concerned with systemic side effects of the collagenase. And we'll get more into that shortly. Some of the ineffective treatments that have been looked at and are not recommended in the current guidelines are shockwave therapy. Patients did have improvement of penile pain, but there's no clear benefit to reduction in curvature or decrease in plaque size. Radiation, many just observational studies with no clear efficacy, and of course obvious risks of exposure and secondary urologic complications. Many oral agents have also been tried, including vitamin E, tamoxifen, procarbazine, L-carnitine, and PDE5s, but they're not approved in Canada for treatment of Peyronie's disease. They're used mostly as symptom management for people with ED or penile pain. And topical treatments are coming down the pipe, but there's just small studies, poor design, and no real pre- or post-treatment measurements of the studies that have been looked at so far, but may be something down the road. So now we'll focus more on Xiaflex and what that kind of brings to the table, and look at how that was developed. In the early days, 1930s, Weinberg and his colleagues found that Clostridial histolytica culture media had interesting properties, that they were able to degrade horse tendon, and this was something interesting to them, and they tried to apply this to medical processes. It was first isolated in the lab by Innes Mandel and his colleagues in 1953. But it took a while before this really got purified and bought into by the pharmacy companies. It was undertaken by several groups after some push from the researchers, and the proposed disease states that kind of sealed the deal were for burn and dermal burn wound debridements using a topical therapy, intervertebral disc herniation to try and dissolve that pulp with a herniated disc, not doing any aggressive surgery, and Dupuytren contractures. These were kind of the things that really got us thinking that, hey, maybe we can use this for Peyronie's disease, given the crossover between Dupuytren's and Peyronie's. In the 1980s, purified collagenase was ready for human injection and was created by Biospecifics Technologies, and the formulation was used as more of a proof of principle, research background, wasn't any large-scale development of the collagenase at that point, and they didn't have funding to really take it to the next level. It wasn't until they hired on Auxilium Pharmaceuticals as a marketing player to provide more funding for the company to then take that into larger trials for FDA approval of the medication. So the first trials that were done on Peyronie's disease plaques were done by Gelbard and colleagues in 1980. They showed that there was an 87% reduction in the Peyronie's disease plaque dry weight when they had incubated it for 48 hours with this collagenase. So this was our first idea that, hey, this can dissolve Peyronie's disease plaques and may have benefit in patients. Del Carlo, he repeated the study with 3 patient plaques, and again, 88.6% reduction in dry weight overall and reduction in size. They looked at the plaques histologically after the treatment, and there was microscopic evidence that there was preserved elastic smooth muscle and nerve fibers, as well as a reduction in the overall burden of collagen. So the first phase 1 trial done in patients was by Gelbard and colleagues. You'll see his name come up over and over. 31 patients with Peyronie's disease, anywhere from 2 to 60 months. They injected collagenase over 3 days, consecutive days, and they noticed improvement in curvature of 20 to 100% of the 16 patients that were investigated. This is based on penile tracings. They had significant change in the plaque size 4 weeks post-treatment in 4 patients. Pain was eliminated in almost every patient, 13 out of 14, and the ability of patients to have sexual intercourse was restored in 3 out of 4 patients. Side effects were pretty minimal: injection site pain, ecchymosis, and there was 1 corporeal rupture in a patient who had intercourse within the 2-week recommended no intercourse time period. The mean follow-up at this point was 9.8 months. So this was our first time seeing some of the side effect profiles of this drug, and it kind of paved the way given the improvements that patients had for future studies. Ramping things up, Gelbard again did the first randomized controlled trial with 3 injections on back-to-back days again, and found significant improvement compared to the control arm. It was a small study, but allowed others to kind of get on board with the treatment. Jordan and his colleagues in 2008, again 3 injections, but spaced out a little bit longer, over 7 to 10 days. 50% of patients had improvement over 25% in their degree of curvature. And then Gelbard kind of trying to fine-tune the protocol a little bit in 2012. Used 2 injections spaced 1 to 3 days apart and repeated every 6 weeks for 3 total treatments. And at this time, they were thinking maybe their Dupuytren's contracture world was coming out with tractional therapy for Dupuytren's contractures, and thought maybe that would have an increase on the response that patients had. So Gelbard used modeling, which is applying traction to the penis, which I'll get into in a second. And it helped improve the curvature of these men at the end of the treatment study. And here's a graph here of the response to modeling of Peyronie's plaques. Patients who underwent treatment with modeling, putting traction on the penis and kind of using the plaque as a fulcrum, had an overall response that was 54% improvement of their curvature. The penile curvature percent change was 30% versus negligible in the control arm. And when patients were investigated for no modeling, there was no difference between the treatment and control arm. So this was a study that really took us forward to the phase 3 trials, and that protocol was used. So this is the first large randomized controlled trial, phase 3, called the IMPRESSI trial, Investigation for Maximal Peyronie's Reduction Efficacy and Safety Studies. 832 subjects overall. There was 4 treatments in this study, 4 treatment cycles of 2 injections, separated by 6 weeks. Their patients were stratified on the degree of curvature and were randomized in a 2-to-1 fashion so that more patients got benefit of the drug, and all patients were required to complete the PDQ. The protocol they used was in-office induction of erection on initial evaluation to measure the point of maximal curvature so that they could follow this over time. They used a dose of Xiaflex of 0.58 milligrams. They injected to a single point in the Peyronie's plaque where the patient had maximal curvature, and the plaque was modeled by stretching the penis using the plaque as a fulcrum 3 times for 30 seconds, and this was a day to 3 days after the second injection of the treatment kind of dose regime. This was done by investigators, so they had to bring the patient back into the office to put their penis on stretch. So it was very intensive for the patients, but allowed them to have strict follow-up and kind of encouraged patients to keep returning. The eligibility was that the patients had to be healthy, stable relationship with a female partner or spouse for over 3 months, and willing to have intercourse, which I don't think was much of a stretch. They had to have Peyronie's disease for over 12 months with stable disease, and their curvature had to be between 30 and 90 degrees. Those being greater than 90 degrees were more likely to undergo surgery or require surgery, and those less may not have had enough symptoms of their Peyronie's to warrant treatment. They had to speak English and be able to give consent. To exclude patients, again, just a list here, some of the highlights would be ventral plaque. Patients with plaques on the ventral side or ventral curvature. Hadn't been studied yet whether or not collagenase would have any urethral complications, so these were excluded just for patient safety terms. It wasn't included in the phase 1 or 2 trials. Hourglass deformity, because there won't be any point of maximal curvature at that point. Calcified plaques were also excluded as they thought that the drug wouldn't penetrate through the plaque. Plaques that were proximal to the base of the penis, and blood thinners, things that would cause more bleeding or hematomas, and then no sufficient erections with the trimix or prostaglandins that were included in the preliminary workup. And as Winston Churchill said, a dead bird never leaves its nest, so these patients would go on to more artificial erection devices. So what were the results? They showed a mean percent improvement of 34% in the patients who had collagenase treatment and 18.2 in the placebo group. The overall improvement was 17 degrees or 9 degrees in the placebo. The mean reduction in the PDQ symptom bother domain was about 3, -3 for the treatment group, and patients who had placebo also had improvement in their PDQ, but only about 2 points difference. Overall, patients found that they had an improvement of their PD-related quality of life of 60.8% in the Xiaflex injection group versus 30% in the placebo group. So pretty substantial placebo effect in these studies, but nonetheless, the treatment arm did show more benefit than placebo. Having more patients, you have more adverse events, and again, the main highlights here are penile ecchymosis in 80% of patients, penile swelling in 55, and penile pain in 45. These were transient and did resolve mainly on their own. Occasionally, they had some more serious side effects, including corporeal ruptures in 3 cases. One was from intercourse within the no-no zone, where they said no sex for 14 days. One was from a missed thrust, and one was from vigorous intercourse 14 days after treatment, cycle 3. Yeah, they had no definition for vigorous intercourse, but you can use your imagination. There was 3 penile hematomas as well. One had to be aspirated and one had to be surgically explored, and they ended up doing a Nesbitt plication. So overall, the percent success, one of my slides got deleted here. The Xiaflex had been tried with calcified plaques. I'm not sure why it got dropped here, sorry. It was a study done on, I think it was just around 40 patients, whether or not calcified plaques were going to be treated with Xiaflex or not. They stratified patients based on presence of calcification or not and looked at their response. The percent success for patients based on whether they had calcific disease or not showed that 40% of patients, the percent success of greater than 20% decrease in curvature in the calcified group, roughly 40% of the patients had that, whereas almost 70% of patients with no calcific disease had an over 20% decrease in their curvature, indicating that Xiaflex may not be beneficial in the calcified disease. Also, patients who had baseline curvature of 30 to 60 degrees had less treatment success than those with over 60 degrees curvature. When comparing the severity of the calcification, they had stratified it by mild, moderate, or severe, and then didn't really notice any change in the moderate to severe versus no calcific disease. However, when they did parse out the moderate and severe patients, they did find significance, 28.1% improvement in patients with no calcific disease versus 10% in the severe group.
Is it really the calcified plaque excluded?
They were. This is a second study, and I apologize. My slide with the study name got dropped here, but yeah, it's another study to say, can we include calcified plaques in future treatments? So this is kind of moving forward past IMPRESS, whether or not more patients can be included to reap the benefits of Xiaflex injections. So this was, patients were having to come into the office over and over, multiple injections, coming in for modeling. This investigator, Raheem, said, this seems crazy. Let's try and reduce the number of overall treatments that patients need to save time and save money. So what he did was injected 0.9 milligrams of collagenase, so double the dose almost of the IMPRESS trials studies in multiple positions within the penile plaque, and injected at 4-week intervals for only 3 doses. Patients did their own self-modeling, so they didn't have to come in for penile stretching, and they used a vacuum device twice daily. The vacuum-induced erections had to be sustained for 1 to 2 minutes, and they did this 6 times twice a day. 53 patients were included in the study, and their inclusion-exclusion was similar to the IMPRESS trial. So here's just a quick outline of the differences in the protocol. You can see here the IMPRESS trial had 14 visits, and the duration of treatment was for 24 weeks. With the new trial that was proposed, the number of office visits were 4, including the initial assessment, and the duration of treatment was only 12 weeks. Overall, the results were pretty much bang on with the IMPRESS trial, and so this was thought to be a viable option to improve the efficiency of treatments in patients undergoing this therapy. So do we actually need physician modeling? If these patients were able to do the modeling themselves with the use of a penile pump, do we need physician modeling at all? Ralph and colleagues saw that there was benefit of modeling, but that patients had been doing this on their own, so they wanted to quantify this. They had patients stratified to collagenase with vacuum, with or without modeling, and underwent 4 treatment cycles. Overall, they found no difference in curvature and no significant change in the PDQ of those who were doing their own modeling versus vacuum. So then patients with the calcified plaques. Oh, sorry, this slide was supposed to be earlier. I apologize. Patients with ventral curvature, they started getting upset, and they said, well, hey, how come we can't get this injection? Let's try to get this approved for ventral plaques. The fear with Xiaflex into the ventral plaques would be that the corpus spongiosum would have some degree of degradation with the collagenase and possibly cause urethral injuries, fistulas, strictures, that kind of thing. So Alum and his colleagues in March 2019 published or has a paper accepted which looked at patients with ventral plaques. They were included in their study. There was 230 patients. Only 11% of those had ventral curvature. They injected 0.9 milligrams, which is the higher dose at the point of maximal curvature. And patients underwent aggressive self-modeling each time they voided 6 weeks post-final injection. Overall, they found no increase in the adverse events and no urethral issues, but their questionnaires didn't really address urethral complications that well, and it was left to patient reporting, so unclear exactly if there was any adverse events from that perspective. Here's just the results from the baseline to endpoint curvature. Patients with ventral lesions showed an overall improvement of 49% in their curvature, and the degree change was almost 30 degrees, which is quite significant. Compared to the dorsal curvatures, is the most common, the percent change was only 25%, so half of what the response was in the ventral curvature patients. So this is kind of the first study that looked at this and saying that it may be a safe option, and in fact these patients might even respond better to Xiaflex treatments. Here's just an overall breakdown in the percentage improvement, and statistically significant were patients If they had greater than 90% improvement of their curvature, the best responders were those with ventral plaques, this dark blue here. Lateral is lighter blue, dorsal is lighter yet, and overall is the lightest. So overall, patients did better with ventral curve deformities than overall or dorsal combined. Important to note that only 11% of patients had ventral curvature in this study, so the numbers weren't that high, and further studies should be used. Yeah. Mm-hmm. Mm-hmm. Yeah. Yeah. This was kind of the only one that I could really find on ventral curvature with any significant recruitment. But again, their questionnaires, they didn't ask about dysuria, flow, that kind of thing, and short follow-up. So maybe these fistulas or strictures will develop years and years down the road. So still has yet to be proven. So what are we doing at VGH? Dr. Flanagan provided me with this protocol that he's using in the clinic. Patients are evaluated similar to the IMPRESS trials. Induced erections of at least 8 out of 10 rigidity to accurately describe the plaque and the degree of curvature. Notes lots of measurements, including the distance from the corona to the maximal curvature, if there's hourglass deformities, indents, hinges, axial stability or instability, stretched penile length, and the circumference of the penis. Moving forward, this is going to give us the most information to follow these patients and determine success. He ultrasounds them with characterizing the penile plaque and uses duplex penile ultrasound if their erections are poor at baseline. Patients are monitored, obviously, when they have these injections. If they don't resolve, and they're given phenylephrine to bring the solder down. Patients are offered observation, traction, or verapamil injections for active or acute phase Peyronie's disease, and they're offered Xiaflex plus traction or surgery if they have stable disease or their plaque is not conducive to Xiaflex. We use a modified protocol of the IMPRESS, but we have two regimes. The 8 injection protocol is similar to the IMPRESS trial, but we space the injections 7 days apart, and it's treated for 4 cycles. There's a 3 injection protocol, 1 injection at a time, spaced 1 month apart for 3 months. And Dr. Flanagan likes to use a 3-point fan injection just to increase the spread of the drug, but the needle inserts at the point of maximal curvature into the tunic. Recommending no sexual activity for 2 weeks, and uses penile modeling and penile traction using a vacuum device for over 3 hours per day if possible. Or sorry, using the Penny Pro, that's that egg-shaped suction cup, for over 3 hours a day if possible, patient willing. Oh, okay. Yeah, prevent. Yeah. Okay, thank you. So what does this all cost? It's not insignificant. Each injection costs the patient about $1,400, and based on a 3 injection schedule is $4,200. This equates to around $180 per degree of curvature improvement that patients get. So not a small chunk of change. Most insurance companies are willing to cover about 80%, which drops it down to $36 per degree of curvature. But if men are unable to have penetrative intercourse, this can be well worth the money for them. One of the problems with researching Peyronie's disease is that there hadn't really been any good animal models, and this was a reason for the delay in bringing Xiaflex from the initial treatments into large-scale FDA-approved studies. But there has been some advancements in this. Various substances have been injected into penises of all kinds of animals, including colchicine, chlorhexidine, fibrin, cytomodulin, and TGF-beta. TGF-beta is now kind of the mainstay, and this induces scarring of the tunica albuginea. activating fibroblasts and causing collagen deposition. It induces sclerosis and a PD-like plaque formation histologically, but unfortunately it doesn't really give us any curvature in these animals. There also doesn't seem to be any significant calcification with these models, which is one of the drawbacks of using these mice or these rats. One study just in 2018 looked at chlorhexidine injections over multiple times, and this induced much more scarring and did induce a curvature, which appeared histologically similar to Peyronie's plaques, but it's still kind of up in the air whether this will be useful in investigating Peyronie's disease treatments. So now we'll talk just quickly about a few treatments that are being thrown around out there that are in the early days, which may have some benefit in the future, but again, these are just investigational. Kind of the most promising one, or the most interesting that I found, was multipotent stromal stem cell therapy, or mesenchymal stem cell therapy, injection of human MSC cells that are implicated in immunomodulatory, antifibrotic, free radical scavenging capacities. It's been interesting to see how they've been introduced into wound healing issues of patients with large wounds or burns. They have many factors that they can influence biologically, including secreting growth factors, cytokines, and influencing the overall modeling or remodeling of disease processes. Exact mechanism is not fully understood, but seems to increase the apoptosis of fibroblasts and kind of modulate their deposition of collagen. And like I said before, they have been seen to decrease scarring and hasten wound healing in patients with injuries or burns. Castaglione and his colleagues looked kind of biologically at what was going on with MSC injections using a stromal vascular fraction, which is just a way of deriving these cells from adipose tissue. This was done from patients who had liposuction done. And they injected these into rats who had Peyronie's disease induced by TGF-beta. They used 24 rats, and they either received saline, TGF-beta to induce a plaque, or TGF-beta plus these adipose-derived stem cells 1 day after the TGF-beta induced plaque injection. And they showed reduction in collagen 1 and 3, as well as elastin with the MSC cells. And you can see here, this was the stromal vascular fraction here, which contained the stem cells, and here was the sort of Peyronie's disease control. And you can see that collagen 1 has less expression than in the MSC injection group, and collagen 3 as well. And they used quantitative optical things to really definitively tell you that these bands are lighter than the others. Erectile function that was tested on these rats is used by electrical stimulation and measuring intracorporeal pressures, and it was found that the TGF-beta induced rats who had Peyronie's disease-like plaques had reduced erectile function, but injecting them with the stromal vascular fraction, which contained the stem cells, brought that back or restored erectile function somewhat. They repeated this study using a few more rats and spacing out injections of the TGF-beta induced plaque process, and they used human adipose-derived stem cells in a similar fashion. 1 week post second treatment with the TGF-beta, the rats were euthanized, and then 1 month after the treatment, 1 week post second treatment with the stromal stem cells, the rats were euthanized, and they were followed for another month to fully characterize the genetics of the remaining rats. So what did they find? They found that overall gene expression of the rats showed an upregulation of many signaling proteins here, CCL13, CXR4, are chemokine ligand and receptor. PLAT is a plasminogen activator, which would be induced in scar formation. Serpin H1 is a collagenase inhibitor molecule, and TGF-beta, which is known to cause fibrosis, was also upregulated in the Peyronie's disease control group. TNF was increased in the adipose stem cell treatment group. This is thought to help kind of modulate the deposition of collagen by the fibroblasts in the group. Overall, they showed a decrease in the amount of collagen, and the ratio was higher, collagen 3:1 in the Peyronie's disease only rats, but the significance of this isn't really known. The rats who were treated with the stem cells did have more organized appearing collagen fibers on histology, but there's no change in erectile function. The last thing I'll just quickly touch on is platelet-rich plasma. This is something that's been seen in the media big time. It's used for all kinds of things with no real data to support anything. But one small study by Matz and colleagues in 2018 showed that patient-derived platelet-rich plasma was safe and feasible. They injected autologous PRP fractions into patients intracorporeally in 4 patients for erectile dysfunction, intralesionally for Peyronie's disease in 11 patients, and 1 woman with stress urinary incontinence was treated transurethral to see if this had any benefit on her urinary incontinence. For the Peyronie's disease patients and ED patients, they noticed mild pain and bruising were the side effects mainly, which kind of makes sense. And there was no real measurement or mention of degree of penile curvature, no control group. So you can't really draw too much conclusions about whether or not this is effective treatment for Peyronie's disease, but might be something, as a first step, patient safety kind of study here. The 1 woman, interestingly, who had the transurethral injection noticed a 50% decrease in pad use, but there was nothing more objective or quantifiable on that. This is the kind of stuff that your patients are going to see in the media. Regenerate your sexual function with the O shot or the Priapus shot. The O shot is the female version, which they'll inject into who knows where, and the Priapus shot, you can inject that really anywhere you want, but there's no data to support it. But they do make it look pretty nice in that this guy's had a certain rejuvenation, and I think you do get, it comes with a free 6-pack as well. So they say it's been seen on Dr. Oz, the news, even the Oscars. They must have had an advertisement or something. I don't know who. George Clooney might have recommended it. I don't know, but yeah, it's the list of indications is broad, but the research supporting it is not. So patients are going to ask about it. They'll see it. It's offered at certain places around Vancouver, but it's still investigational and lacking really any substantial evidence. But, just like to thank Dr. Flanagan for helping me out putting this presentation together, and I'll take any questions if you have any.